Hi, everybody. It's Dr. Kat Gallus, and we're about to kick off another episode of Carpools and Cannulas. I think this is episode 21, hard to say. And Dr. Greer is joining us in 2 seconds. And tonight we are going to be talking about, let's see, there you are.
Hey, are we really at like episode 21? I lost count, really.
Yeah, I had to figure it out. My sister's logging on. My social media person who used to be my coordinator is like, what episode is this? She was bugging, and I'm like, oh, I don't know. I gotta count it all out and figure
Not
it
a clue.
Yeah, she keeps me on point.
That's good. My social media person is really slacking, probably because it's me.
You? Yeah, Malia just keeps the posts going. Otherwise, it's so hard. It's so hard.
It is hard. I write all mine once a week and keep them on a spreadsheet, and then my staff uploads them to Facebook Business Suite, which does Instagram and Facebook, and then I do all my TikToks myself. So,
yeah, you're a beast, man. The TikToks.
Yeah. I do delegate. I send out the YouTube stuff for other people to upload. Thank God, because that's just a lot.
Well, and just to bore everybody with technical challenges, getting these off my phone onto Dropbox into YouTube, like I'm at the Wi-Fi.
Instagram doesn't want you to download stuff either, so you have to buy an app so that you can download them, and then the upload to Dropbox takes forever, so that we can share them with each other, and then the upload from Dropbox to YouTube ages.
Yes. 100%. Anyway, whatever. The things we do for our patients and in order to educate people, right?
That is what we're here for, and because we get to hang out every couple of weeks.
Yes, that's right. We get to talk. So I think, did you get the Galaflex? Did you bring some? Oh, you're so good. Very nice. So we were going to talk about mesh, and I feel like it's become more and more, it's entering the conversation a little bit more and more now.
Mm-hmm.
I know I've seen patients where they said, who I didn't personally think that they needed mesh, say that they were told by another surgeon that that's what they needed or whatever. And I was like, yeah, I mean, it's like some things everybody, once you start using it, you might start using it for all the things. But yes, Galaflex. So, but there are definitely some indications. So want to explain to everybody what breast mesh is?
Yes. So this is Galaflex. This is my demo piece. We don't implant this, but just so patients can see it. And it's really flexible. It's got these little tabs for sewing in. And there's also one that's got a rim on it that holds shape. I don't mess with that one. I just do this one. It comes in several different sizes, but you can trim it to fit, and all the sizes cost the same. So I always just get the large one. And it comes in rectangles too, which is nice for the abdomen, but it's a resorbable mesh. So it's completely broken down by your body, and your body lays down collagen over it. So it basically just makes your own healing more robust. I've also taken it out of people. Have you ever taken it out?
No, but I've heard it. Sometimes it's still there.
Yeah, I took it out. Somebody had, let me think, Pexi Aug, and then I was removing implants, and she only had it on one side, so I took it out for symmetry, and it was just this little rectangle of thicker tissue. It was very easy to remove, but it was clearly her own tissue. So it's nice that way because there's not a foreign body down the road like some of the hernia meshes or the TBT meshes, if you've ever heard of those causing problems. It's not the same stuff. It's totally replaced by your own tissue.
Right. But however, it's a scaffolding, which is usually what all these meshes accomplish. But it's interesting because you're right. I still remember using Gore-Tex sheets for giant abdominal wall hernias in my general surgery and sometimes plastic surgery days, which is completely foreign. It's never going to incorporate. You're basically just putting it in there to bridge something. That has its own issues. Usually as a plastic surgery resident, we were championed with getting it out.
Yes, I remember picking out your own mesh in clinic just because people would have huge sheets and it would get exposed and it would get infected and it wouldn't heal, but you can't just tear apart their whole abdominal wall.
Right. So, so that was one iteration. Then everyone was super excited about your own collagen replacing the mesh, as Candace is pointing out. I think is that was alloderm, right?
Yes, we were all super excited about that. And it
Right.
was great in some ways. Like, it definitely thickens the tissue. It doesn't always incorporate. We've all had to take it out when it's just like floating around in there.
Mm-hmm.
And it's thick too. It's so alloderm is just a sheet of human collagen. It's human skin that's had all the cellular components removed, so there's nothing there for your immune system to react to, and your body grows into it, but it's thicker than Galaflex, so
Right.
that takes a little bit longer. It doesn't always get incorporated, and it's really stretchy.
Yes, it is very stretchy, and it definitely is prone to infection. And these are, so people weren't using it for cosmetic, case indication. So in breast reconstruction, it was mostly where it was used. So yeah, so there's a lot of other circumstances in there that makes it a higher risk operation in general anyway. But when they thought about using it for cosmetic cases, the price of using human derived tissue is extremely
Very high.
So it made it less popular. You need to use a drain also, not fun if you don't have to.
And it's not great for things like abdominal wall because it stretches.
Yes, and then the stretchy part. So Galaflex came along and is a great product because it doesn't stretch, and kind of where you put it is where it ends, so you know exactly what you're getting. And gets incorporated by your body. It dissolves. It's essentially made of suture. That's
right. And I feel like we don't see that same risk of seromas, which are fluid collection.
No.
That's something we would see all the time. Now, granted, again, breast reconstruction, there's this huge dead space because they've taken out all the breast tissue, goes all the way up into the axilla where your lymph nodes are. That right there is a setup for seromas anyway. But I think there have been some studies showing that alloderm maybe produces a little bit more reactive fluid, and Galaflex does not seem to do that.
No. Have not had that experience. Also, the lack of drains is helpful. The cost is, less. You don't want to put it in willy-nilly because there is a cost associated with it, of course.
Oh, with Ehlers-Danlos. I think we can confidently say nobody has any idea, probably.
Yeah, I don't know. We're always a little reticent to operate on those patients, and it depends on what form of ED they have too, because there's different subtypes. So,
yeah, and to know how it's getting replaced, we would have to put the mesh in and then have taken it out of somebody. So just the likelihood that there's a surgeon out there in the world who has A, operated on somebody with Ehlers-Danlos, B, used Galaflex, and then C, gone back and taken it out is pretty low. But if you're out there, message us because we want to hear.
Please let us know. We want to know. So it has made its way into the cosmetic revision business. It's also, I don't do breast reconstruction anymore, but it's also being used in breast recon as well because of the same alternatives, that we talked about. It could potentially in some places be maybe preferred. So that being said, most of the cases I've used it in have been with regards to an implant, so revision, breast augmentation, mastopexy. So the implant pocket is no longer exactly where you want it. So you want to reset where that implant's going to sit on the chest wall, and putting this in and suturing it in place has been a game changer versus other techniques, right?
Like a perfect little hammock. It works great. I actually do use it in primary apexies and reductions as well.
Okay.
Not just revision.
Do you use it for everybody or just patients that, okay, so what's the type of patient that you would think this person needs a breast lift or a breast reduction? I think they would benefit from some reinforcement. How do you decide that?
Those are the patients who come to me and they say, I want them smaller or higher. I want upper pole fullness, but I don't really want to change the size and I don't want an implant. Okay. So then we talk, sometimes I'll do fat grafting. If they just want a more youthful shape, because there's like the pancake shape. Mm-hmm. It's not like the perfect 25-year-old that you see in the movies, which most people don't have breasts that shape. But if you want to get closer to that look, the Galaflex just gives a lot more support. And it will get more of that tissue into the upper pole without resorting to fat grafting or implants if they don't want something down the road or if they don't have any fat to graft.
Okay.
It's nice for that.
So I would also think that patients who've had like a lot of weight loss, so their skin's been stretched out, or kind of the young patient that maybe grew really fast. So you look at them and you see stretch marks already on their breast, or their breast got really large and then small again with pregnancy or what have you. That people where you're a little bit worried about the skin quality, that might be offering some extra support. Do you do a different pedicle then if you're putting it in?
I actually don't. And you know, the other people it's really good on is, so if somebody's got stretch skin, but their glandular tissue is really dense, because like say they're 30 and they've lost a lot of weight, you can rearrange that gland and it will hold the skin. But for those women in like their 50s and 60s where their breast is more adipose tissue than glandular, you can't really suture that well. Those are perfect people for Galaflex. And
Okay.
what I do, I still do a superior medial pedicle for all of my reductions and pexies. And then I just elevate a skin flap right at that superficial breast fascia layer, just like probably the lower 4 centimeters between the nipple and inframammary fold. Go laterally until you hit good rib contact on each side, and then like one little stitch to the periosteum on each side to just lift it up. And I literally like lift the breast up a little as I stitch it. And then, you know, a couple above and below to tack it flat, redrape the skin flaps, and it really gives nice lift.
Nice. Very nice. Okay, cool.
Yeah.
I definitely used it when, you know, like I said, the implant is trying to make its way either down your chest wall or
or like out to the side,
out your armpit, around to your back. And so old school techniques were like taking the capsule that already formed or just suturing, putting internal sutures, which often fail over time. Like you just, for whatever reason, it didn't hold up the first time and now it's not going to hold up again. So those cases have been really successful. I have used the 3D mesh with the rim.
Yeah, how is that?
It's okay. It's definitely easy to sew in because it holds its framework. But in thin people, you can feel that rim for quite some time. So,
well, and you can feel the mesh. I warn patients, like you can kind of feel something wrinkling under the skin for a couple of months.
Yeah.
Until it incorporates.
Right.
Now, have you ever used it on abdominoplasty?
I have not. I have not used it in those patients.
I've done a few.
You have? I feel like again, they have terrible fascia. You might want to lend some strength to that.
That's when I use it.
Okay, because then where are you suturing it to? Pubic symphysis? Like where on the body are you putting that? Or is it just
I actually just do it as an overlay.
Just
because I figure it's going to create a little more collagen and stick a little bit better. So I've done it if somebody's got a really wide diastasis in the upper abdomen, or I have reason to worry that their fascia quality isn't great because, you know, massive weight loss patients often, their fascia is just so thin. So you can overlay that just to reinforce the repair. And then I had another patient who I swore had a hernia on the left lower quadrant, got a CT, no hernia. It was just super weak. So I overlaid Galaflex there too. And it's really cost effective. Like you can get a big rectangle for the same size as 2 sheets for the breast. So.
Right. And I believe at the women's conference, somebody talked about taking that rectangle and cutting it into 2 pieces and then kind of putting it as a diamond shape at the bottom of that inframammary crease, just as like a little diamond hole, depending on the patient. So then you could get 1 piece and use it on 2 patients to just reinforce the inframammary crease. So for everybody, that IMF fold is kind of where your breast stops. It's like where your breast attaches to the chest wall, and you know it doesn't slide down your abdomen. And
it can if it gets obliterated during breast augmentation, and that's when you get that double bubble. It's bad.
Yeah. So it's a zone of adhesion that isn't like an actual, it's very easy to blow through and can create problems if somebody undermines that and sometimes needs some reinforcement. And so if that's the one area where you're worried about, you know, a recurrence of that area coming back down, the 2 little diamonds essentially help reinforce that. Most of my cases, not only is it falling down their chest, but it's like moving out to their lateral chest wall. And so you really need that whole hammock, you know, effect. And I think that helps a lot. And it, like I said, there's little stretch to it, so it's going to go where it's going to go. Yeah. There are a couple other products out there since this is not a SpawnCon sponsored by Galatea.
Yeah. Hey, Rob, my Galaflex rep, where are you, man? You were supposed to get us Starbucks for this. He in no way promised that, by the way.
So there's Durasorb, which I don't have a ton of experience with. I know Ashley Gordon in Austin has been using it. But it's newer to the market. So just like everything else, the first to market usually has the advantage of getting the word out there, people working with the indications and having more experience with it. And then I also have recently used Telebio. It's a ovine, so sheep derived product that also has mesh integration.
Wait, so sheep is ovine as opposed to bovine?
Yeah, bovine.
Where did you learn that?
I don't know. I feel like I know that from my wound care.
I didn't know that.
Oh yeah, well, you're welcome. So let's see. So I've recently used that as a product. So again, because it's newer, I don't have the longitudinal. So I've been using Galaflex for at least 4 or 5, no, longer than that, because I was still in the Navy and we were using it. So 5 or 6 years. What about you?
I think probably 2 to 3.
Mm-hmm. Yeah. And again, if you start by just using it for revision cases, depending on how many revision cases you do, you may or may not be using it a lot. I do a fair amount of revision cases, and sometimes people will the other nice thing about it is, since it integrates really well when these older ladies have these crazy ruptured implants and all kinds of stuff going on, and I'm just trying to reestablish a pocket after I've cleared out the debris. It's very helpful, and I know it's not going to create a foreign body problem for me, like i.e. infection, which would be unhelpful. Yeah. Also, I don't know if there's been studies out what its effect is on recurrent capsular contracture. I'm sure that's the direction they would probably go in if they could.
Yeah,
right?
although you gotta wonder, because it's not, when we've, like in breast recon cases, if we're worried about CapCon, you coat the whole implant.
Right.
And that's not really what you do with Galaflex. Although if it worked, they could make like a little Galaflex sock that you could just slide the implants in. First tray of clothes, that'd work really well.
Right. Yeah, so that's interesting. So all of this is trying to find a balance between the capsule that forms around the implant and making it work for you, and either reinforcing the capsule or putting the capsule where you want it. But anytime you put an implant in, a capsule forms, and it can either work in your favor or not work in your favor. And this is another tool in the toolbox in terms of breast implant revision surgery to get the pocket where you want it. And that's, I don't know that anyone's using it. Well, no, I take that back. I was going to say no one's using it for primary breast aug, but there is one category I can think that they use it.
Oh, and I could see if you're doing super huge implants, which, those are going to cause problems, but I could make the argument.
Yeah, so I do believe that there are surgeons who are doing super large implants, 800 cc's, the overexpanded saline, 1000 cc's. So if you want like a 2-liter bottle of Coke in your chest, you could argue maybe adding something to support that internally might get you a little farther down before the whole thing starts, causing problems.
Yeah, because you just can't, especially just depending what size you're starting from, you can't fit that size implant without blowing out the infirmary crease. It just doesn't, or the whole thing's sitting way, way too high.
Yeah, and the stretch on all of that is non-anatomic on some.
Yeah, although on some people, I've put in 800 cc implants that look totally fine. It just really depends on individual anatomy.
At least in San Diego, the people getting those implants tend to be, 100 pounds and B breasts, in which case there's no way.
Yeah, it just doesn't fit.
It's not going to work. If that's your aesthetic, I don't do those cases.
Sometimes I'm glad to be in the Midwest. It's a more conservative goal.
Yeah, I saw a picture of Kourtney Kardashian on Instagram this morning. My daughter was actually pointing it out and suggested that her abdomen looked like an old lady's, but the rest
Oh
of
my gosh, is that the one where like her skin is just like adherent to her abdominal wall and like her belly button sticks out because there's no fat? That was not good.
So I'm like, what are you talking about? And then I looked, and it's just funny that from a 14-year-old standpoint, it looks like an old lady abdomen. I'm like, okay, be careful with your words.
Yeah, an old lady abdomen, it's not.
But from a professional standpoint, it just looks like skin on abdomen.
Yeah.
It's a little alarming. So it's a different aesthetic sometimes in Southern California, not necessarily a better one.
Yeah, I like Cleveland for that reason.
Yeah, well, I know. I would say that the weather is better, but today it's been kind of bonkers. So
it was beautiful today. I can see my azaleas blooming out the window because my new house had like huge azalea bushes. It's amazing.
That's good.
Sometimes we beat you out.
Yes, that's true. And it is a little disappointing when people come to visit and then it's a couple of days where it's cold or overcast, and I'm like, I mean, overwhelmingly the days are better, but it's not perfect every day. So
yeah. Hey, when are we gonna have WPS in Cleveland? Nobody's really fighting here for conference, I found.
It is gonna be in Charlotte though. Or Charlotte.
Hopefully I won't get like all flights canceled again this year.
I know. I hope not. February's tough. So, all right. Well, so just to recap, I know we couldn't see the eclipse last night either. It was cloudy. The marine layer moved in.
Yeah.
So in where I live, it's always a constant battle between the water temperature and land temperature, and when they collide where I am, it just makes everything, it's called the marine layer, and you can kind of watch it move in sometimes. So it's this like rolling cloud, and it's cold and kind of dense fog at the beach, but if you go in a mile and a half, it's like burning hot. So that's the breaks. I'll still take the water though. But so all right, so tell me, okay, top indication for using mesh with breast surgery, would you say is your most common use of it?
It's actually going to be primary pexy or lift.
Okay.
I like it. I like it enough. I was asking around to figure out who could use it so I could fly and see them.
Oh, right. No, I've done that too. I actually was going to use it for breast reduction. A friend of mine who practices in Huntington Beach, and then COVID hit. And then it's, fast forward 3 years and I've not gotten it together. But yeah, I think that's interesting. And I do want to see, I would love to see some video of, different ways of people, because people talk about it, but they don't necessarily, and present about it, but they don't necessarily show us intraoperative videos. So you would say your most common.
I should take one next time I use it for a lift.
Yeah, absolutely. I'd love to see that. And then I would say my most common indications, revision, breast augmentation.
Yeah.
So it's a no-brainer for that. So if you're considering either of those operations, be sure to ask your surgeon about mesh. And then I think, what are we going to talk about in a couple weeks? What should we do?
That is a good question. What do you guys want to hear about? Leave them in the comments. We're watching. Let's see. We hit labiaplasty last time. We've definitely talked about aug. I know we talked about brow lift recently.
Yeah, and thighs.
Oh yeah, thighs were good.
Yeah, I do agree. A video of Galaflex being placed would be helpful and informative to all. So maybe next time. Tomorrow I'm doing a paniculectomy. I'm not sure we can devote an entire half hour to that.
No, although, we could, and this might be a useful talk, just talk about the differences between straight up paniculectomy under insurance for issues versus cosmetic abdominoplasty, because they are really different.
Yes, I think that would be helpful. Let's go there. And then maybe talk about liposuction as an adjunct to tummy tucks.
Ooh, yeah, because that's good. And my practice has totally changed on that in the last 3 years.
Great.
Yeah, okay, that'll be a good one, Ken.
Yay. All right. Well, I'll see you in a couple weeks. I have the California Society meeting is coming up this weekend, so maybe I'll learn some new things and bring some new topics to the table as well.
Nice. I will see you in 2 weeks. I'll put it in my calendar.
All right. Have a good night.
You too. Bye, everyone. Thanks for watching.
Bye, everybody.